It is now time for our panel. Please welcome Susan Dentzer, President and CEO of America's Physician Groups, Terry Wilcox, Co-founder and Chief Mission Officer of Patients Rising, and Dr. Mark McClellan, former CMS Administrator and Founding Director of the Duke-Margolis Center for Health Policy at Duke University. Welcome, everyone. Dr. McClellan, you are a doctor and were CMS Administrator 20 years ago. What are some of the challenges in getting this reform done that might not be so obvious to the broader public?
Well, it was a little bit easier then. The Medicare spending levels were lower, and it was on the tail of some major reforms in Medicare. We had just enacted the Medicare Modernization Act, which put an emphasis on making care more prevention-oriented, including prescription drugs, and that meant more, not less, interactions with physicians and especially primary care practices. Since that time, as Medicare costs have continued to rise, we've tried a couple of major steps to try to get payments more aligned with the costs of delivering care. And most recently was a set of reforms that implemented a payment system with quality adjustments that also was not tied to growth in overall healthcare costs. So in more recent years, we've seen growing interest in trying to find ways to get the payments more aligned with spending growth, but it's become increasingly hard as Medicare spending is higher and the actuaries, the technical experts that add up how much this costs show that it adds to spending. So we've gotten back into this old habit of Congress having to step in every year and at the last minute try to fix payments, and they're in the process of doing that again right now. I do think there's a chance to shift that by moving to different ways of paying for physician care. And at this point in Medicare, more than half of people are in Medicare Advantage plans that don't just pay on a fee-for-service basis, but try to support coordinated care for people. And even in the traditional Medicare program, most beneficiaries are in what are called accountable care arrangements, alternatives to traditional fee-for-service payment. So I do think there's a solution, and it's great to have another physician coming in to head CMS at such an important time. I do think there's some solutions in the direction of, hey, not just sticking with fee-for-service payments that are never keeping up, but supporting physicians, both primary care physicians and specialists in helping to drive into these more effective, prevention-oriented, coordinated, simpler payment models. So that should be part of the solutions going forward.
Gotcha. And, we're focusing on, physicians and their ability to stay in practice. Susan, you represent physicians. Can you speak to the current challenges they're facing and what their biggest concerns are as they face a fifth consecutive year of Medicare physician pay cuts?
Absolutely. And the 360 physician groups that we represent are committed to value-based care. They are committed to being held accountable for the cost and quality of care. So all of them are participating in some of the alternative payment models that Mark was referencing, as well as heavily in Medicare Advantage. Our groups care for about a third of all the MA enrollees in the country. What has happened since 2001 is that the Medicare physician fee schedule, which we should note doesn't just pay physicians, right? It also pays nurse practitioners who bill through Medicare, physician assistants, clinical psychologists, and others. Because there's no automatic inflation adjustment and accommodation for practice cost inflation built into that fee schedule, in real terms, inflation-adjusted terms, it's fallen by about a third in terms of its level of payment to physicians. Now, payment is a function both of the payment level and the provision of services, right? So to some degree, our sector is compensated by just supplying more services. So even if you're paid on a unit cost basis, if you're doing more services, you can manage to hold your own. But that's not an optimal situation. We want the best care for the right patient at the right time and in the right amount. So what has happened again is that without this inflation adjustment, the effect of the fees in the fee schedule, they have fallen in real terms. They have put physician practices and others in the position of having to try to make it up on volume, if at all possible. And we're very heartened by the fact that there are voices now suggesting not just addressing the latest cut in the fee schedule that is in place now for 2025, but also incorporating into the fee schedule an inflation adjustment that will take account of this almost automatic increase in costs for physician practices that has occurred from year to year. That has basically, it's important to note that most physician practices now across the country are under serious financial pressure from rising rents, from rising labor costs. We know that labor costs have risen substantially. There are labor shortages across the healthcare workforce. And all of that poses an extreme amount of financial pressure on physician practices. Many of them can barely keep up with the demand that they now face, let alone the demand that they expect to face, particularly from a growing Medicare population, especially the part of the population with multiple chronic illnesses, lots of healthcare challenges, and frankly, getting older. So a real quandary for physicians at this point. And that's why we're very, very hopeful that we'll see two things happen in the near future. First of all, a rollback of the almost 3% physician fee cut that is scheduled, that is already in effect for 2025. We would like to see that eliminated. And we would also like to see an inflation adjustment incorporated into the Medicare physician fee schedule going forward.
And Terry, you work in patient advocacy. At the end of the day, this is all about making sure that patients get the care that they need. Can you speak to the implications of whether this trend continues? Obviously, there are concerns that there won't be enough physicians, they'll be priced out, but it goes beyond that, doesn't it?
Well, definitely. I mean, patients are the ones who ultimately feel the impact of these cuts. I mean, it actually falls on the shoulders of patients and their caregivers. It's not just the doctors. So when physicians can't afford to see Medicare patients or having to make it up on volume, as they say, so they don't have as much time, access suffers. I mean, as somebody who has taken care of seniors over the past several years through COVID, and I had 3 and now I'm down to 1 as of the beginning of this year, but I can tell you, as somebody who makes those appointments, who works towards making sure that they have continuity of care, they have all of the things that they need for their prescriptions, et cetera. It can sometimes take several calls, and part of that is just the mass amount of volume that's happening in the physicians' offices, and it's also very difficult to get into new physicians. So there is a real physician shortage, I want to say, here already underway. And so then to take this and add pay cuts on top of that, I think is detrimental to the patients and especially the seniors in this country.
Thank you. And Mark, you were CMS administrator. The AMA, our sponsor, is in favor of increasing the threshold for Medicare tax or Medicare budget neutrality, which people say is the cause behind these cuts. Is Medicare needs to be budget neutral for under a certain threshold. How do you feel about calls to increase that? We've seen numbers suggesting doubling that or even quadrupling that.
Well, I mean, as you heard from the other panel, I think Terry put it very well. If there's not adequate payment for physician and their teams, then there's not going to be adequate access to care in Medicare. I think that the challenge is twofold. One is increasing the funding so that these payment rates match cost. But I'd like to add to that, as Terry described, the experience of care for a Medicare beneficiary is not easy right now. And I think that's partly driven by the fact that for many physicians, they're still getting paid on this fee-for-service basis where the rates keep getting tightened down. And what you do in that kind of volume system to stay in business is you have to see more patients in less time. And that means it's harder to provide the supports that each of them need. Another component of the bipartisan agreement to try to at least get through this year and get on a better path for physician payment was an additional payment to the physicians and their teams that moved into these so-called alternative payment models that are about paying for the whole practice, like direct payment to a stronger to a primary care group to build out the data infrastructure and bring in more team-based approaches to care, to use digital technologies and AI and telehealth, the other things that Medicare traditionally hasn't paid for very well, if at all. That would be an additional sort of 3.5% under the bipartisan agreement that we have now for the next year, and that would be actually expected to be paid for by savings that would come from not having to have as many patient visits in person and having better support for coordination of care and just more convenient and efficient ways of delivering care, like many of Susan's member organizations are participating in right now. So I don't think we can get the budget numbers up enough just by paying more in fee-for-service, especially with so many examples today of physicians who are doing better by moving away from that fee-for-service, hamster wheel.
Right.
Right. I would just jump in and say we concur with that. We think payment has got to move along two tracks. As long as there's a traditional Medicare program, a lot of providers will be paid through the fee schedule. And keep in mind, many of the alternative payment models are still based on classic Medicare fee-for-service payment. So as long as that end of the world exists, and we think it will for a while, we've got to continue to improve the functioning of the Medicare physician fee schedule, as Mark said. And that, by the way, can include adding new features to the fee schedule, not just addressing budget neutrality, which is probably appropriate, but also adding new features into the fee schedule that can put resources in the hands of, say, primary care practices that they can't now get through the fee schedule. The second track, though, that the nation is clearly following, and our groups are certainly following, is taking on patients in Medicare Advantage and being paid in particular for our groups directly by plans who are delegating a lot of the risk over to our groups, and then they get the resources that they need by virtue of risk adjustment and other features in Medicare Advantage to actually produce the kind of advanced primary care strategies that are so critical now to taking care of an older and sicker Medicare population. So we definitely agree, we need those two tracks, and as long as we have them and continue to support them, we'll be able to deliver the kind of care that ideally the patients that Terry references would want to have.
Right, and turning to Terry, we're talking about alternative payment models. To your knowledge, are people, made aware of these alternative options that could be available to them? Is there an outreach for that? Do they, are they being told of that?
No, I mean, I can tell you as somebody who goes to many appointments, who takes care of seniors, it's really just about, it's a fill out this form, it's a check-in, it's in my personal experience and in the seniors that we talk with, there isn't a lot. But one of the things that we advocate for and we think about a lot at Patients Rising is many of the things that we've talked about here, which is seniors and people with chronic conditions in general, they need a continuity of care and, not a revolving door. And they need plans and doctors and practices and everyone, Medicare, CMS, to think about the long-term health and well-being of a patient and not just an annual, insurance, because our system is set up where we think about the long-term health and well-being of someone for 12 months, and then we start over again, right? And so I think patients are not made aware of those payment models, at least in my experience, but I think, seniors would definitely be open to that. I know I would be open to that because my mother-in-law, my stepmom, now my mother-in-law, just passed away at the beginning of the month. My stepmom lives with Alzheimer's, and there's a lot, of things to manage for that. And it's not just on an annual basis.
Thank you. Lightning round of questions, starting with Susan, and then we can go to Terry and Mark. What does comprehensive Medicare payment reform mean for the groups you represent or the people you work with? Susan?
Well, it's going to have to happen in stages because that's the way Congress will address these issues. Number one, we need to see a rollback of the almost 3% Medicare physician fee cut in this year. And we would second Mark's reference about the need to restore the advanced alternative payment model bonuses, which are frankly gone now for this year. So putting those back on the docket, in effect, restoring those AAPM bonuses and also redressing the fee cut is essential. Beyond that, we need to revisit the 2015 MACRA law, as it was called, to examine some of these features of the fee schedule that we think need to be fixed. And in particular, addressing the inflation update, as I said earlier. But more broadly, we're in favor of pushing as far as possible toward alternative payment models. So that could potentially mean dismantling other aspects of what was put in place in 2015 in MACRA in order to speed up the transition to alternative payment models, because we fundamentally agree that more population-based payment in the system as opposed to fee-for-service-based payment is the way to go. And that with true accountability of physician groups on both the cost and the quality, we can deliver superior outcomes for patients.
Thank you. Terry, what does this mean for your group?
Well, I agree with everything Susan just said, as far as, we need to take care of this, because at the end of the day, the people I represent, which are the patients, they don't need more hurdles to care. They need doctors who can afford to see them. And so ignoring this problem, it's as I said at the beginning, it's patients who end up paying this price. So that is where we sit. We believe Congress needs to act on this and move forward for patients. Medicare is supposed to be a promise. It's a promise to access care when you need it. And right now, that promise is breaking for many seniors in this country. So thank you.
Mark, from policy standpoint, what does this Medicare payment reform mean for you?
Well, look, and we see this in our work at Duke-Margolis on helping to support better policies. These changes that we've talked about are badly needed, and they're hard for physician groups that are stretched right now to undertake. But we have seen a growing number of successful examples of physician practices that are moving in the direction of using team-based care and digital and AI technologies and ways of coordinating with community-based providers, providing relief for some of those caregivers that we just heard about. And you have to change the way we pay to get there. So the challenge is, how do we do that at the same time as we're helping the providers along? I do think, we haven't had that many physicians or clinicians leading CMS in its history. My expected successor, Dr. Oz, is coming in with this perspective very much in mind. So now's a great time to build on the successes of the past with the urgency to get to a more sustainable but more effective non-fee-for-service-based healthcare system.
Thank you, Mark. And thank you to all of our panel for joining this discussion today. Susan Dentzer, President and CEO of America's Physician Groups, Terry Wilcox, Co-founder and Chief Mission Officer of Patients Rising, and Dr. Mark McClellan, Director of Duke-Margolis Center of Health Policy at Duke University. Thank you all for joining us.
Thank you.
Thanks for having us.
Thank you.
That brings us to the end of our program. Thank you to all of our wonderful speakers. On behalf of The Hill and our sponsor, the American Medical Association, we'd like to thank everyone who joined us today. Thank you very much and have a great rest of your day.